Today's speaker is Robert Heimer. He's a professor here at the Yale School of Public Health, director of CIRA's Interdisciplinary Research Methods Core. Currently, his research focus includes both field-based prevention work and laboratory investigations of disease transmission risks. The field-based work concentrates on the scientific evaluation of prevention programs serving drug users. These include syringe exchange, hepatitis vaccination, and overdose prevention. The laboratory work concentrates on the virological assessment of the risk of syringe sharing and other drug injection behaviors that may transmit HIV and hepatitis C. He's done work here in the US and internationally, and today we'll be focusing on the past, present, and future of HIV and AIDS in Russia. Dr. Heimer.
Thank you for that nice introduction. I haven't even said anything yet. I'm not sure I'll say anything by the time I'm done. I'm going to give you an overview of our work that we've been doing and some of the analyses that we've been attempting to do with data that we've collected in Russia and that are available in Russia from other studies as well as our own, in an attempt to paint a picture of an unfolding HIV epidemic that remains unchecked. The bottom line is the past, the present, and the future are all pretty bleak. You can all go now. But just as an outline of our talk, I'm going to spend a lot of time talking about the emergence of drug use and drug use patterns in Russia, so that you have a better understanding of the situation there and what it is that that makes the epidemic in Russia kind of different from many other places. Part of this big difference is the difference in drug types that exist in Russia. We'll get into that in detail. We'll explore in even more detail, has one form of the drug played a special role in the expansion of the epidemic in Russia. When I'm done with that and have confused you enough there, we'll focus more on the work that we've done in the city of St. Petersburg and look at the possibility, probability of this epidemic expanding from one that was concentrated in injection drug users to the general population. A thing that the Russian government wants to ignore despite its increasing likelihood. So a couple definitions, just so we set the table for this. A phrase I like to use, I don't know if any of you get it in your any of your EPH classes, but the word is syndemic, and syndemic has been coined over the last couple of years, and it means the concentration of two or more diseases or health conditions in which there's an interaction between them that makes each of them worse, and that move together as a complex. In this case, we're talking about the syndemic of drug use and addiction, HIV, hepatitis, tuberculosis, sexually transmitted diseases. At the end of the talk, I'll begin to get into the subject of bridge populations, and that's the group of individuals that are needed to move the epidemic from the high-risk group of drug, in the case of Russia, drug users, into the more general population. And another term that I will introduce in this talk is the force of infection, and that's the rate at which susceptible individuals become infected by a pathogen, or the rate at which susceptible groups of individuals become infected. Now, the syndemics in Russia really began with an epidemic of drug addiction in the early 1990s. The parallels to the United States here are interesting, because prior to Russia's, Afghan war that ran for a decade, a little longer, a little shorter now than our current Afghan war, the abuse of opioids and stimulant drugs was uncommon. But it grew in the 1990s with the fall of the Soviet Union, with the opening of borders, with the collapse of the Soviet state, with the anarchy that existed in many parts of Russia that coincided with the fall of communism. in an attempt to control this, the federal government, as it was re-centralizing its control, introduced a federal law on narcotic means and psychotropic substances. Now this had the negative effect of making drug addiction actually a crime, and at the same time discouraged prevention programs, harm reduction programs such as needle exchange or access to syringes, and actually banned substitution therapy, which is the only sort of evidence-based form of effective treatment for opiate addiction. And the opiate we're talking about mostly in Russia will be heroin. And as this was happening, Russian cities were experiencing, many of the Russian cities, especially those with any money, were experiencing expanding heroin markets as young and disaffected people started using drugs that were different from the drugs that their parents used, which was mostly vodka. They went out and decided, well, let's try other cool drugs like, heroin. And there was a heroin chic in Russia, just like there was in the United States about that time. And the epidemics that are associated with injection drug use, HIV, hepatitis C, fatal opiate overdose among drug users began in the late 1990s, and HIV was first noticed in the westernmost Russian city of Kaliningrad in the summer of 1996. So we're now talking about an epidemic that's about 14 years old, 15 years old. Heroin addiction is a huge problem in Russia. There are an estimated approximately 2 million heroin injectors in Russia out of a population of 145 million. That means more than 1% of the population has a history of injecting heroin. In addition to commercial heroin, which you could, for instance, find on the street corners about 6 or 7 blocks from here, if you knew where to look. Russian drug users also manufactured heroin at home, a substance they call chernaya, which is the Russian word for black, and you'll see why in a bit why it's called black. They also manufacture their own stimulants, psychostimulants, methamphetamine and methcathinone. These are common in some locations in Russia, but not everywhere. Drug availability in Russia varies widely, but generally speaking, once the commercial heroin market comes to town, it stays there. It doesn't disappear. Most places start off with the homemade drugs and then move on to heroin. And the only sort of exceptions we've seen to this is there have been heroin shortages from time to time in Russia, most notably when the Taliban clamped down on heroin, on opiate production in Afghanistan, and for the year after that, at the start of the Afghan war. Now, there are some studies in some single locations in Russia that have linked homemade drug use to increased HIV prevalence, but those are more associations than any kind of causative thing, so we don't know really what to make of that kind of association. But just so you understand how this homemade drug is prepared, notice the clock on the left, it's a few minutes after 11 when this production was started. You take poppies, you grind them up, you alkalinize some water, usually by adding sodium bicarbonate, and you cook the poppies in this alkalinized water to extract from it the alkaloids that include morphine, codeine, papaverine, and some other things, but you're of course most interested in the morphine, which becomes heroin at the end. The mixture is boiled and filtered, and then the opiate alkaloids are found in this liquid. The used poppies can be saved for a second extraction. We'll talk about that in a bit too. The alkaloids are then back extracted into an organic solvent that doesn't mix with water, and extracted again out of this organic solvent into an acid solution. Usually sulfuric acid. It's pretty intense and serious stuff. But all of these things serve to reduce the volume of liquid, which is further reduced by boiling off the acidic solution. And you can see this stuff in the bottom of a white enamel pot is pretty black, hence the name chernaya. Now you have an opiate alkaloid, mostly morphine. It's reacted with acetic anhydride to yield diacetylmorphine, which is also known as heroin. And you can still see it's pretty ugly and black. The mixture is, again, reduced by boiling and being filtered. Now, the starting material for this can be, as I showed in these pictures, ground up poppies, but it can also be opium gum, which is the sap of the poppy pod rather than the pods themselves. And, you know, if you had in your hands some opium poppies, the gum from that would be 11% morphine by weight. But many of the Russians don't have access to, you know, papaver somniferins, the opium poppy. They have the ornamental poppies that they grab from the fields. I was talking to a Russian friend of mine who said his parents used to grow poppies by their dacha, their summer home, but they stopped doing it because the drug users would come by and steal all the poppies. Sometimes, especially if you start with the poppies themselves and not the opium gum, you end up with a solution that contains lots of microfibers. And you don't really want to be injecting those microfibers, and you don't really get rid of them by filtering these things through a towel. But what some Russians do is try to clarify, if you will, their poppy solution at some stage by adding blood and having the blood curdle. This is actually a classic French cooking technique. If you want to clarify a bouillon, what you would do is make your stock and leave it on the stove, and then you'd make a raft that contains chopped up vegetables and egg white, ovalbumin. You bring it to a boil, the ovalbumin curdles, it all rises to the top, you skim it all off, and you get a beautiful clear bouillon. Well, a Russian isn't going to waste an egg on this process. So, and of course they have syringes and access to another source of albumin, serum albumin in their blood. So they take their blood and they put it in and they boil it up, and they then can skim off this stuff or filter it away, and they end up with a clearer solution. And you'll see a picture of it in the last slide of the series on making chai. And when you do that, it looks sort of a brownish yellow color rather than black. If you're making your heroin from non-opium poppies, it's going to be very weak. You're going to get a little bit of opioid buzz, which you might get from some codeine, some morphine, some heroin that you've got in that mix, but it's going to be low concentration. And so what Russian drug users do to get that specifically heroin nod, the sleepy feeling rather than the euphoria, is to add an antihistamine. I don't know how many of you take antihistamine sometimes for your cold and find it makes you drowsy. Well, if you inject it, it makes you very drowsy. And so the Russians use this strong antihistamine, Dimidrol, which is very often added to their opiate mix to give them the satisfaction of a drug that actually sort of narcotizes them. So there's the chernaya in the syringe when it was done. You can see this took about 2.5 hours to make. The final product is ready to be injected. Alternatively, you can store this inside syringes for later use, or it can be sold, and it's almost invariably sold as a liquid. You're not going to dry this down. And the storage often occurs inside of syringes. And one of the things that people have considered as a possible route for HIV transmission is that if this stuff is stored inside of a contaminated syringe and you give that syringe or sell that syringe full of drug to somebody else, you can transmit the virus, possibly. Now, the HIV epidemic in Russia takes on this interesting characteristic that prior to 1995, or 96, I guess, almost all the cases of HIV infection, the first 1,000 cases detected in Russia, and mind you, this is HIV infection, not AIDS. People hadn't been sick long enough for many of these people to get AIDS. This is HIV detection by serology. Most of the cases were either sexual, among heterosexuals, men with sex with men, or hospital-based nosocomial infections. However, in 1996, there was a dramatic and significant change where all of a sudden most of the contributors to the 1,000 new infections or 1,100 new infections identified in that year alone were among injection drug users. And ever since then, the epidemic has continued to expand. Some very rapid increases at the beginning of the last decade, with 80,000 or so new cases detected in 2001. And the funny thing is that, you know, for a while it looks as though the epidemic was declining, but then again, late in the last decade, it shot up again. In fact, there were nearly 60,000 cases diagnosed in 2009. Probably as many cases will be diagnosed again in this year, 2010. So this is an epidemic that's far from under control. It's an epidemic that is concentrated overwhelmingly in injection drug users. At least 3/4 of the cases are in people who have a history of injection drug use. A lot of cases are still of unknown origin or unknown etiology, unattributable to one of these risk categories. Many of those people may also be injection drug users who've successfully hidden their injection drug use status from the Russian government. But the thing about Russia is Russians think of themselves as unique. And so even though this epidemic growth looks like the epidemic that's occurred in many places among injection drug users with a rapid increase in HIV, high prevalence of HIV in drug users, Russia has to invoke unusual causes. It's just something that the Russians do. We're different from everybody else. Therefore, what caused our epidemic has to be different. And this anecdotal reporting of blood inside syringes and blood being used during homemade heroin preparation led to the speculation that contaminated drugs themselves may be fundamental to the epidemic. It's not the syringes, the drugs are contaminated, and if the drugs are contaminated, then it doesn't matter whether or not we give out clean syringes, we're not going to prevent the epidemic from being transmitted. Therefore, we don't need needle exchange, which has effectively curtailed the epidemic in many other parts of the world. So the Russians say, you know, screw it to harm reduction, screw it to needle exchange. We don't need it. It's not going to change our epidemic. We need to focus on healthy lifestyle so that people don't use drugs. And we were curious whether or not this belief that it's the homemade drugs that cause the epidemic was really true or not. So we wanted to test whether or not homemade drugs were capable of carrying the virus and transmitting the virus from person to person. Was it actually contaminated drugs? That's hypothesis one. Hypothesis two is that it may not be the drugs themselves, but certain behavioral features of homemade drug use. As you see, this is done in people's kitchens. It takes a while. It's a very social practice. Maybe this leads to excessive syringe sharing, people hanging around. Could these behavioral features, particular to homemade drug use, that were once common throughout Russia, explain the rapid epidemic rather than more traditional reasons why epidemics spread among drug users, which is lack of access to clean syringes. So the question is, how does HIV enter the chernaya? Well, it comes in this blood that people may be using and adding to, to help purify their drugs. If the person adding blood is HIV positive, then HIV is added. Can also enter the drugs during storage. If the drug is stored in a syringe that was previously used by someone who is HIV positive, then that drug solution might have some HIV floating around in it. So we're going to test both, does virus survive during manufacture or during storage? And we did this by replicating chernaya manufacture in our laboratory. Based on ethnographic observations, still photography, videos, we elaborated a protocol for a prototypical chernaya production, and we did this in the lab. We got a license from the U.S. Drug Enforcement Administration that allowed us to actually make heroin here on campus. Don't try this in your dorm room. Infected blood was then prepared that contained HIV at titers common among infected people to see if we could recover virus from these Chernaya preparations. As a preliminary control experiment, we wanted to be sure that the Chernaya itself didn't reduce HIV when it was added to HIV replication when added to the culture. So we first mixed target cells in HIV-infected blood, then added the Chernaya. We saw no diminution in this case of HIV replication. So the Chernaya, diluted as it was in our tissue culture combination of cells, virus, and Chernaya, we got fine viral propagation. So we had a working system, and then we went and made the Chernaya with blood, and we did this 11 times. And never could we propagate and recover HIV from the Chernaya. So this is actually not a surprising result. You know, you saw how the preparation was made. You saw there were, you know, caustic chemicals being used. You saw there was heating and boiling and evaporation, all of which is toxic to the virus. No surprise that despite the belief in some quarters that the drugs come contaminated because people use blood, that's, as we say, fiction. But the question is, could the syringes in which the drug was routinely stored transmit the virus or result in the survival of virus that could be transmitted when that solution is then injected into someone who's HIV negative? So what we did was we loaded the syringes with about the amount of blood that might remain in a syringe with a detachable needle, and then, just as a control, we flushed those syringes with saline and introduced it into our culture system, and we could recover virus from every syringe that was handled in this way. However, when we filled the syringe with our Chernaya solution and then introduced that into culture, we found about an 80% reduction in viability or recovery of HIV from the syringes, suggesting that the Chernaya or something in the mix from the poppies or the chemicals are in fact toxic under the circumstances in which the Chernaya and the virus are mixed first instead of the Chernaya being added at the end in culture. Now, I mentioned to you that the poppies can be saved and reused again, but in the case when this happens, the yield of morphine alkaloids will be greatly reduced. So re-extracting these used poppies can help us determine whether the inhibition that we're seeing results from the chemicals or something from the poppies. And what we found was, in fact, with the return of viability from syringes in the second preparation of Chernaya, that it's actually probably something in the poppies themselves that's inhibiting the ability of virus to reproduce in culture, to propagate in culture. So it isn't the chemicals, it seems to be the poppies. Now you might think, well, wouldn't this be a wonderfully effective anti-HIV medication? But imagine that this is a mix of 20 microliters of blood and about 2 mils of solution. Just quickly do the math and figure out that in order to inactivate HIV in your blood, you'd need about gallons and gallons, maybe dozens of gallons, or hundreds of gallons of Chernaya, and there's no way you're going to get that into your blood anyway, so it's not going to work as an anti-HIV medication. It might be interesting to try to figure out what exactly it is in the poppies that resulted in lower viability, but that's not something that I have the skills in my laboratory to do or any interest in trying to figure out. So if it's not the drugs, is it homemade practices? I'll give you the skinny on this. There's no evidence that from our studies in 11 Russian cities where we collected data throughout Russia in 2003, 2005, that behaviors of people who inject homemade drugs currently or initiated their drug use with homemade drugs are at higher risk than people who use commercial heroin. So it isn't the behaviors, it isn't the drugs themselves that are responsible for the rapid proliferation of HIV in many Russian cities. So since we couldn't confirm either hypothesis, what is the explanation for why HIV is increased so markedly in some cities and not in others? And what we ended up concluding is that it's not the Chennai at all. Actually, it's the conversion to commercial heroin. And to make this determination, we analyzed several sources of data, looking at an ecological data on HIV prevalence from entire regions. That's data set 1. Data set 2 is data set from this liquid drug study that we did in 11 cities. And data set 3 is from a more recent second-generation surveillance in 8 Russian cities. And we use what's called the preponderance of information approach, since these are all sort of correlations rather than conclusive proofs. So here's the ecological data, and what you can see is for a bunch of about 25, 26 cities, here's HIV prevalence from low to high, ranking in terms of high prevalence. So we've got some cities that are all the way at the top of HIV prevalence. We've got some cities that are nearly all the way at the bottom among the 89 administrative districts in Russia. And what you can see is that low prevalence is associated pretty strongly with homemade drugs, and high prevalence is associated with commercial drugs, with a couple of exceptions that are worth discussing. Yaroslavl, where commercial heroin has predominated for a decade now, it's got low prevalence. One of the reasons for this is that prior to the introduction of commercial heroin in Yaroslavl, there was a harm reduction program that introduced peer-to-peer education about safe injection and about access and a subsequent program to allow people to go to pharmacies and get clean syringes. This seems to have made a difference in keeping the epidemic in Yaroslavl from ever occurring. Chapayevsk is interesting. It's a small city of about 70,000 people in the same province, Samara Oblast, as Tolyatti, a city of 1.1 million. Remember, these data are at the level of the province. So the fact that there's no HIV that we could detect in the drug users we interviewed in Chapayevsk would have no effect on HIV prevalence in this oblast, where in a city like Tolyatti, by 2002, more than 50% of drug users were already HIV positive. So this anomaly is one that's just an epidemiological oddity due to the difference between understanding things at the level of the city versus the level of the province. But this is an ecological approach. It's HIV prevalence is for the entire population, not just for people who inject drugs. Remember, we're talking about the difference between region and city. So the second drug study, this liquid drug study that we did in 11 cities, again, found a very strong correlation between the percentage of people who report using commercial heroin in the last 30 days and HIV positivity in the population. Now, the problem with this study, and why it's not completely conclusive, is that HIV positive is not done by serological testing, but by self-report. And self-report is, you know, as work we've shown in St. Petersburg, can be notoriously inaccurate. So the best study, in terms of looking at this, would be the second-generation surveillance, which was done in eight Russian cities. And what we found, again, however, is a fairly strong correlation between high levels of commercial heroin use and high HIV prevalence, with a couple of exceptions. The one exception being Ariel. But what's interesting about Ariel is there's a large percentage of people who inject stimulants, which could result in unsafe needle practices. I guess the other one, no, that's about it. Oh, and relatively low HIV prevalence in Naberezhny Chelny. Naberezhny Chelny is a city in the Autonomous Republic of Tatarstan. Tatarstan also began HIV prevention work targeted to drug users with needle exchange and peer drug user education back about 2000. So that may help to explain why prevalence has remained low even though everybody injects heroin, the commercial form. The weakness of this really is that the major weakness is that there really are no historical data about when the transitions to commercial heroin occurred and whether or not that transition is directly linked to increasing prevalence. Tried when I was in Russia to get these data, which are to look at entry into drug treatment, into detoxification programs, which is the only form of drug treatment they have, and get data about as a marker for when the market changed from homemade to commercial heroin, to get some interview data from local police about when these things had happened, and to get data about increasing AIDS cases from the local AIDS center. Many of this is supposedly publicly available data, but publicly available data are not really publicly available. You have to pay to get them, and the fellowship that I was on didn't allow me to have money to pay people. So I got a little bit of the data, which seemed to support the fact that when heroin comes to town, the number of drug users go up, which could, of course, be at the root of why you're seeing increasing prevalence, is that not that one drug is more likely to transmit the virus than the other, but rather that just there was a larger group of people who are in the at-risk pool. So that's it for sort of the history, the past. We have been working in St. Petersburg now since 2000. We've conducted a large number of studies. A couple of cohorts of drug users have been followed. We've estimated HIV incidence, and it's always very high. HIV prevalence in St. Petersburg keeps going up. In the course of the studies that have been done over the past 12 years, HIV prevalence has gone from 2% in drug users on a continuously upward climb till now more than half of the drug users in St. Petersburg are HIV positive. Not a pretty picture, and I find it, those of us who work there find it very frustrating that all this work we do in documenting the epidemic has very little influence on getting the government to change what it does. That's a whole different talk. But we, in our most recent study, which we finished in, well, not, I guess our second to most recent study, that we did with drug users that we concluded in 2008, we measured incidence in cross-sectional studies. Now, you're not really supposed to do this. If you really want to measure incidence, you're supposed to run, longitudinal studies where you get data before and then you get data after, and you look at the number of people who seroconvert over time. The only problem with this is that, well, three problems. One is they're very expensive. Two, in some cases you have high loss to follow-up, which may not be random and therefore may influence your data. And the third thing is that sometimes being in a longitudinal study itself seems to be an intervention that reduces incidence. So, for instance, the Alive cohort in Baltimore, which has studied drug users for now 20 years, found high incidence in the first year, and people were seen repeatedly, every 6 months over these years of this study. High incidence in year one, and then all of a sudden incidence bottoms out and stays low. Why? Probably because part of the thing that you want to do ethically as part of your interaction with a high-risk population is to give them ways in which they can reduce their risk, and that happens. So in some ways, even though you're not supposed to get incidence from cross-sectional studies, if you have adequate methods for trying to estimate incidence, they may be a truer reflection of the incidence in your community. At least that's what we like to believe. And we had two measures of incidence. One was we built into our study a retrospective cohort. We asked people, had they been previously tested? and when they'd been previously tested and when their last negative test was. And so we had a group of people who we knew when they were last tested. Some of them stayed negative throughout the whole study. Some of them became infected between the last time they were tested and the time they were tested in our study. We arbitrarily set the midpoint between when they were last tested and when they were tested in the study as when they got infected, and built this cohort. The second way is this: we tried to use this serological method called BED testing, which attempts to identify those individuals who were recently infected. And this testing takes into account all the people who are positive from the study, retests them to detect those people who are likely to have a recent infection. So first, the retrospective cohort. In our study, we had 322 people who were disease-free, reported being HIV negative at their last test. 65 of them had acquired disease. Incidence rate of 14.1%, 14.1 per 100 person years. That is a phenomenally high incidence rate for HIV. That happens at the beginning of many HIV epidemics among drug users in locations. It's very unusual to find that high an incidence 10 years into the epidemic in any place. It really suggests incredible neglect on the part of the public health sector. When we used the BED assay, we actually found that an even higher incidence rate of 20% per year. Though we know that the BED overestimates incidence. It does it almost every time it's been applied. But these give us a range between, say, 14 and 20% incidence per year. So somewhere between 1 in every 7 and 1 in every 5 drug users who was HIV negative last year is HIV positive this year. So who are these injectors? You know, they're young. Most are 18 to 35. Median age was 29 in our study. 30% were women. A third are fully employed. Many are in school. 10% have a university education. Russia has a 2-tier educational system in which people, after high school, either stop going to school or they go to university. They go to a couple years of training, pre-university, gymnasium education, then go on to university, or go into some sort of vocational training. And another 25% had vocational training. The rest stopped school after the age of 16. But it's interesting, 55% of them live with their parents. And unlike what we think of as prototypical or classical drug users, very few are engaged in illegal activity. These are not reprobates. These are not social deviants. These are just people who happen to have used drugs, many of whom have become addicted to their opiate use as a result of injecting. So the force of infection in St. Petersburg remains drug users to this day. We could control the epidemic if we would provide antiretroviral therapy to drug users. And in fact, latest studies from Europe, the Americas, and Africa all agree that by reducing individual level viral load, transmission can probably be reduced. The Russian AIDS Center refuses to provide antiretroviral drugs to active drug users. They have to be clean for 6 months. If they're put on antiretroviral drugs and they revert to drug use, they're taken off their medications. Clearly, nothing is being done to blunt the force of infection in St. Petersburg. And in fact, this has reached the point that you're now seeing the epidemic spread from drug use, the core drug-using population of injectors, to the broader population. And this occurs, through sexual bridges. Now, of course, injectors can infect each other by either shared syringes or by unsafe sex. But if they have unsafe sex, they can transmit the virus to their sex partners, who in turn can transmit the virus to other non-injectors. And what we saw is that this is not an uncommon possibility in St. Petersburg. 84% of the drug users we interviewed were sexually active, and 2 out of 5 of their partners they knew not to be drug users. So there's a large population of non-drug users having sex with drug users. 46% of the non-drug users are potential bridges to the general population, and that is to say, the non-drug users were themselves having sex with other non-drug users. 41% of these partnerships with potential bridges between IDUs and non-IDUs, and between non-IDUs who were sex partners of IDUs and non-IDUs who were not sex partners of IDUs, were unprotected. 15% of the non-IDU sex partners were already HIV positive. So we're already seeing a great deal of transmission, sexual transmission, from drug users to non-drug using sex partners. We estimate that at least 1/4 of all heterosexual transmission is in St. Petersburg is from an IDU to a non-IDU sex partner, and not within the drug-using population, within the drug-using population, or drug user to drug user, or non-drug user to non-drug user. So here's what the data look like on this chart. Those are the sex partners. Sex partners were continuing to have sex with other non-injectors. And if you try to estimate prevalence in the general population from these data, what we could determine was that, not going through all these numbers, if there are 1.5 million people between the ages of 18 and 45, the population that's most at risk for contracting HIV, then the population in the general prevalence, even excluding injectors, is very close to 1%. These are data from only as far as 3 years ago. Because this epidemic has gone unchecked, one can estimate that this number is increasing and is approaching that threshold of 2% of the general population, at which the epidemic is considered to be no longer a concentrated epidemic in a high-risk population, but rather a generalized HIV epidemic. Now, this previous estimation is based on a simple back calculation, looking at the data on who was infected, how many of them were non-injectors, sex rates among this population, how many cases would be tested and not tested. We can also model the data if we want using mathematical modeling, and these give us very similar results. The estimated prevalence is about 0.8%, again approaching that 1% level, and this is in 2006. We're in the process, actually as we speak, I believe, one of our faculty members is en route to Britain to start trying to put together a stochastic model of HIV prevalence and transmission in the general population based on the data we collected in this study. I hope that he and his British colleagues will have something to present about this, to take these data out, to see where the epidemic is heading now, so that we can report these back to the Russian government, the local government, in the hopes of getting them to finally do something. So, where is the epidemic heading? It's still concentrated in drug users, certainly in St. Petersburg. We're seeing increasing prevalence among drug injectors in a number of Siberian cities over the last couple of years. So the epidemic continues to spread uncontrolled in drug users. It's spreading in the heterosexual population. In some cities, not just St. Petersburg, adult prevalence is approaching 2%. Russia, as I said, Russia is unique. Russia may be the first country on the globe to experience a generalized epidemic of HIV that originated among injectors. No other country has seen that happen. Everywhere else where you've seen a generalized epidemic, sub-Saharan Africa, it's heterosexual transmission. Thailand was on the verge of one, was completely controlled by controlling sexual transmission. Russia's going to be unique. And because they're doing nothing, unlike many of the surrounding countries, to control addiction, we're really going to see over the next couple of years whether or not this epidemic will be generalized. As I said, what's Russia doing? Not much. The Russian government fails to conduct proper surveillance to understand the scope of the epidemic. As an example, in St. Petersburg, I asked them, well, how many drug users do you think you have? And they say, well, we've got 10,000 registered drug users. We must have 10,000 drug users. And I said, but wait a second. You have 40,000 HIV infections. 77% of those are in people who injected drugs. That's more than 30,000 drug users. How can you say you only have 10,000 drug users? Statistics say we only have 10,000 drug users. So we estimated and just published last year our findings on what we estimate to be the number of drug users, injection drug users, in St. Petersburg, and it's 83,000, plus or minus 12,000. Clearly, almost an order of magnitude difference from the city estimates. But the city people cling to what their data tell them. Everything else is irrelevant. The Russian federal government spends less on HIV prevention than the state of Connecticut spends on HIV prevention. I don't know, Leif is just nodding his head in disbelief that anybody could spend less than Connecticut. But in fact, for a population of 140 some odd million people, Russia spends less than Connecticut at 3.6 million people spend. Despite the fact that their epidemic is out of control and our epidemic isn't. Russia refuses, the federal government refuses, adamantly refuses, repeatedly, aggressively refuses to accept internationally accepted methods of targeted HIV prevention. They refuse to believe that what's worked everywhere else in the world to control the epidemic and drug users will work in their country, their HIV epidemic, and even more, they refuse to accept and even actively prohibit evidence-based treatments for those people who have heroin addiction that's at the core of their HIV epidemic. Methadone, buprenorphine are illegal. You cannot treat heroin addiction with an opiate, which is the only proven way of keeping people from using illegal drugs, illegal opiates, in any effective and consistent and long-term method. Instead, Russia uses 10-day detoxification, which is sort of the equivalent of, considering that addiction is a chronic disease that is caused by long-term changes in the brain. It's like you're diagnosed with type 1 diabetes. You go to the hospital, they stabilize your blood sugar with insulin, they release you 10 days later and say, oh, by the way, you can't get any more insulin. It makes no sense unless you begin to understand that the Russian approach to unacceptable behavior is really one based on ostracizing social deviance. And in many ways, there are a large proportion of people in the Russian government and the Russian Orthodox Church who all believe that there's no point in doing anything for drug users You know, in a sense, we will passively let them die. Despite all the evidence that you can amass that says, well, you're not stopping the epidemic from spreading outside the drug-using population, you are facing a demographic bottleneck. You know, your population is 140 some odd million people, and it's actually shrinking. Daily, your country is getting less populated. Your fertility rate is the second lowest in the world. Below, you know, only Italy has a lower rate of fertility than Russia. So you're going to throw away 1 million, 2 million of your citizens simply because they had the bad fortune to become addicted to drugs? But, you know, Fyodor Tuchayev, who is considered the third great of the three Russian Romantic poets, after Lermontov and Pushkin, said Russia cannot be understood by the mind. And I guess that's the bottom line, in a sense, that we have to find, in a sense, non-rational ways of discoursing with. It's kind of like dealing with Republicans and gun control. It's something I have to do. It's something I still believe can be done, but it is something that has its great frustrations, which is probably why I drink a lot of vodka. Thank you.